Much for inviting me to join in this workshop. It seems to be a very popular workshop, so it's very exciting to be involved in the new way of doing things. My name's Andy Rawstron. I work in the Hematological Malignancy Diagnostic Service, which is a multidisciplinary laboratory in the centre of Leeds, right in the middle of the UK. That's the hospital. Currently, like many places, we have limited physical working, and anybody who can work from home is working from home. And so this is where I am at the moment, over in York, about 40 miles away from Leeds, down by the river in a shed. So but hopefully we have good internet, and I've certainly got access to all the cases which come through for analysis. We assess about 35,000 samples a year for hematological malignancies only, and the majority of those are really for mature B-cell malignancies, of which chronic lymphocytic leukemia is the most common to be analysed in the laboratory. And so before we start, I just need to show this disclaimer to say that any of the information that I'm sharing is my views only, and it's not necessarily the views of Beckman nor necessarily the views of Leeds teaching hospitals. We're going to focus on chronic lymphocytic leukemia related disorders, look at a bit of diagnosis and monitoring, and some technical considerations for the approach to disease monitoring, and some current and future applications. So chronic lymphocytic leukemia is it's a spectrum of there's a spectrum of disease. There isn't just a CLL or not CLL. It goes right the way from a very aggressive progressive disease with extensive bulky lymphadenopathy requiring treatment, and in many cases fatal. But at the other end of the spectrum, you can find, if you look carefully in the general population, CLL cells, which by all biological measurements look very similar to those aggressive cells. The number of abnormal cells, or the proportion of people with abnormal cells detectable, moves from very low levels in younger people, but by the time you're aged 90, approximately half of European or American people will have developed a CLL phenotype population in their peripheral blood at very low level. As far as we know, there are no clinical consequences of these, although it may be a sign of a dysfunctional immune system. And so the kind of clinical spectrum is inversely related to the amount of disease that's detectable. In the UK, we see about 7 per 100,000 per year incidence at the moment, but there's a very wide geographical variation. So for example, in Japan, the incidence is less than 0.5 per 100,000 per year. And that geographical distribution, this is not CLL specifically, it's leukemia as a whole, but you can see some really quite distinct patterns. In particular, Africa and certain parts of Asia, as we mentioned, have very low incidences of CLL. And we were lucky enough to do a study out in Africa and Uganda to look at what was going on. Was this just because people with CLL weren't presenting to a diagnostic centre, or was it really that CLL wasn't so common? And what we found was that monoclonal B cells are present in the general population to a similar proportion. So with a high sensitivity assay, about 10% of people will have a monoclonal B cell population detectable. But the CLL, the phenotype's different. So whereas in the UK, it was mostly CLL phenotype monoclonal B cells, in Africa and Uganda, in this rural population, it was predominantly post-germinal center phenotype abnormal B cells, so things that looked more towards the plasma cell end of differentiation than to the germinal center end of differentiation. So I think our first understanding of chronic lymphocytic leukemia is that there is some sort of abnormality in the cell survival characteristics of the neoplastic cells. So something that's common right the way through from those very low-level indolent populations present in the general population through to aggressive disease is some dysregulation of the BCL2 family, the balance between life and death. But there's a variety of different ways that can come to pass. So you can have 13q14 deletions in a proportion of patients. There are inherited susceptibility factors that just alter the balance of pro and anti-apoptotic factors. So, for example, the genes that are common in Europe in CLL patients are virtually absent in African populations. So that's one of the underlying factors that may lead to the ability to develop a CLL type population. And a variety of other things that are maybe less common, such as a BCL2 IgH translocation. The big difference between the sorts of very indolent, low count population, CLL type populations that are found in the general population versus more aggressive disease is down to what sort of immunoglobulin gene the cells have. So you may have underlying factors that predispose you to develop a CLL population, but unless that has a very specific immunoglobulin gene, there won't be any progression of that abnormal population. This understanding came from studies looking at the immunoglobulin gene sequence in patients with advanced disease, patients requiring treatment. And there was a clear separation in outcome between those patients who had a germline configuration, so an unmutated immunoglobulin gene with a poor outcome, versus those who had a mutated immunoglobulin gene that looked like the cells had gone through a germinal center reaction, which had a much better outcome. And when people started to look at these sequences, you'd see that actually quite a high proportion, about 30% of people had a very similar or a stereotyped immunoglobulin gene. And the probability of that happening in a B cell is less than 1 in 10 to the 12. So this was clearly something that was playing a role in the pathogenesis of the disease. And when we look at those stereotyped or similar immunoglobulin gene sequences, what you find is that they're really not present in the cells that are out in the general population, the low count cells in otherwise healthy people. Whereas if you have an expansion of B cells, but maybe not necessarily with aggressive disease, you'll start to see the stereotyped immunoglobulin genes. So signaling through that B cell receptor pathway seems to be essential to developing a high number of abnormal cells. So we have underlying development, ability to develop an abnormal CLL phenotype population being requiring some sort of BCL2 family abnormality, and then to develop a substantial lymphocytosis, you also have to have the right immunoglobulin configuration. And to the best of our knowledge, there are plenty of other abnormalities and mutations that you see in CLL cells, but nothing else that's really pathognomonic that defines CLL as a unique molecular entity. And so a lot of our diagnostic features depend on phenotypic analysis. The main disorders that we have to separate out from CLL would be mantle cell lymphoma and some other post-germinal center B cell type disorders such as Waldenstrom's, marginal zone lymphomas, and so forth that sometimes express CD5. Now, how critical it is to get the diagnosis correct seems to be becoming less relevant these days as treatments start to converge. So you're starting to see that many patients with different disorders that we would have said are different disorders because of the biological understanding will still respond to the same molecules, the same treatments with the modern inhibitor approaches. But if it's chemoimmunotherapy is the main approach, then there are some distinct differences. So, for example, fludarabine cyclophosphamide would be the current gold standard, or possibly the current gold standard that may be being replaced now, but for chemoimmunotherapy anyway, fludarabine cyclophosphamide would be used in younger patients with CLL, but it wouldn't be used in mantle cell lymphoma or Waldenstrom's due to hematological toxicities. But if you're looking at modern therapies with a B-cell receptor pathway inhibitor, so a B2K inhibitor, those are already approved for relapsed refractory mantle cell and Waldenstrom's. So, you know, there are differences, there are different underlying biological differences, but maybe the treatments are going to be the same. So you know, it's kind of interesting to work out maybe what the main approach for phenotyping is, determining what sort of molecular assessments you do downstream in the laboratory. For diagnosis of CLL, the guidelines are fairly fluid. They say that there should be CD5, CD23 expression with weak expression of other B-cell markers, but there's plenty of variability allowed around that. So, for example, you could have a CD5 negative CLL, even though that's one of the primary guides for diagnosis. So what we felt was that because there was no real global definition, we would try to get at least some understanding of what people felt was the standard CLL phenotype and what you could use to guide downstream analyses to determine whether you needed, for example, to exclude an 1114 for a diagnosis of mantle cell lymphoma. This was a fairly broad group of people collaborating to determine what the consensus on an absolute minimum requirement for diagnosis would be versus what the recommended markers would be if you maybe had access to a wider range of diagnostic markers. And there was a clear indication that you couldn't make a diagnosis of CLL without looking at 590, 20, 23 and a clonality assessment, but also recommended was to say that the cells were CD10 negative, CD43 positive, CD200 positive, CD79B weak. And it was felt by the steering committee, the people on this group, that also CD81 and ROR1 would be useful, particularly for looking at monitoring. So if we look at the main see in a diagnostic flow cytometry lab, and by this, I'm kind of not looking at the main B-cell malignancy that we see, which is diffuse large B-cell lymphoma, because in most cases that's really determined outside of the flow cytometry lab. That's determined in the with immunohistochemistry and other molecular features. But for the things where we would try to assign a diagnosis with the flow cytometry, those key markers that we were talking about for CD5, 20, 22, 25, 79B, 23, and ROR1 and CD43. This is the different sort of patterns that we would typically see. So for CLL, CD5 would be strong and CD20 would be weak. In mantle cell lymphoma, you would typically see a more variable expression of CD5, often strong, but sometimes bimodal. Whereas with the other sorts of B-cell disorders that may present with a leukemic presentation, the post-germinal center disorders such as Waldenstrom's, if there is any CD5 expression, it will be fairly weak and the 20 will be strong. All of these B-cell disorders, so all of the non-germinal center B-cell disorders have weak CD22 and overexpression of CD25. So that's helpful maybe for monitoring, but not so helpful for diagnosis. And then looking at surface immunoglobulin versus 23, typically for CLL, 79B will be, and the surface immunoglobulin will be negative, but 23 will be reasonably strong. Whereas if there is any 23 expression in the other disorders, it's often weak and heterogeneous. And then probably the most useful markers for diagnosis are ROR1 and CD43. So ROR1 is expressed only on CLL, some mantle cell lymphomas, and some progenitors, proportion of B progenitors and ALL. It's not expressed on any other normal mature leukocytes or cells in the peripheral blood. So if you see ROR1 positive cells in the peripheral blood, you know that you've got a neoplastic population. For CLL, typically ROR1 and 43 are both expressed. 43 usually very strong, ROR1 often quite weak. Mantle cell lymphoma will have variable expression, sometimes like CLL, sometimes not so much. Whereas for post-germinal center B cell disorders like Rawstron's and marginal zone lymphoma, typically both of those are very weak. So what we see in terms of our instant samples of the CD5 B-LPDs, B lymphoproliferative disorders, approximately 65% of cases coming into our lab have an absolutely typical phenotype for CLL. And in those cases, we never see a cyclin D1 translocation. We've tested about 1,000 now. And so I think in general, if you have a completely typical phenotype, there's no real need to be testing for a cyclin D1 translocation. We do see MYD88 mutation, that driver for Waldenstrom's and other B-cell disorders, in a small proportion of patients, but often that's actually in a separate subpopulation. So in general, that fully typical phenotype, about 2/3 of cases, and we know that we'll be able to monitor the disease easily. If there's a single marker atypical, maybe 20 to 50% of those have another driver, either mantle cell lymphoma with a cyclin D1 translocation or a MYD88 mutation. And if there's no CD23 expression, more than half of those will have a different biological underlying biology, and the phenotype for those cases may often not be suitable for monitoring. So that's our overall sort of pathway for CD5 positive B-cell disorders. A fully typical phenotype, we can say it's CLL, and we look for prognostic markers. If there's anything atypical, we check for a cyclin D1 translocation. We'd also may look for a cyclin D1 translocation in any case that's 200 negative, but it's not that isn't obviously like follicular lymphoma or something like that. Or we also check for, if the phenotype's atypical, look for a MYD88 mutation, and it may be more down Waldenstrom's or lymphoplasmacytic lymphoma pathway if it's 200 positive, ROR1 negative, CD43 negative. So this is how it fits into our multidisciplinary analysis of all B lymphoproliferative disorders. I haven't talked about germinal center phenotype disorders. As I say, in most cases, the majority of the work is done by the histology department. And I haven't talked about hairy cell leukemia because we haven't really got time today. What we've looked at are these types of disorders, the pathway down through typical phenotype for CLL, where we're looking then for abnormalities that maybe predict the type of treatment that's needed because of prognosis, differentiating from mantle cell lymphoma and Waldenstrom's marginal zone lymphoma, lymphoplasmacytic lymphoma, where the final diagnosis will rest on morphology and immunohistochemistry. Okay, so in terms of the diagnostic features, flow cytometry plays either a fully diagnostic or a heavily supportive role. But probably our major workload now is really measuring residual disease and response assessment. So probably 80% plus of our work is people who've had a diagnosis, had treatment, and they're either in remission or under follow-up, which is the situation for many years in patients with CLL. So we're going to look at monitoring over the next few slides. The classic response assessment rests on normalization of full blood count, normalization of resolution of lymphadenopathy, and so forth. And these kind of morphological approaches, looking for residual nodules in the bone marrow, they're highly effective at predicting, identifying patients with a poor outcome. But actually, the majority of patients now are getting complete remission, so morphologically undetectable disease and long survival rates. And so there's been an interest in using more sensitive measures to assess response and monitor. What we've seen across the B-cell malignancies, immature and mature, B-cell malignancies is that if you look with higher sensitivity assessment that captures all of the disease activity, you'll see typically a stepwise improvement in progression-free survival per log depletion in disease, and that fits with the kind of exponential growth pattern that you'll see in disease. We are probably mostly in the laboratory able to measure around here at the 10 to the 4 to 10 to the 6, so one in a million to 1 in 10,000 neoplastic cells. And these generally probably don't equate to a full cure. The modeling suggests that you probably have to get below 1 in 10 to the 8 or lower to actually achieve a cure, so that patients would be very probable to die of another, would not die of their disease. But we have to make estimations of what's likely to happen based on the types of assessments that we can make in the laboratory, around about 1 in 10 to the 4 to 1 in 10 to the 6. And I guess a sort of overview of monitoring technologies is that the type of technology you use or is available, is developed, varies according to the how well the patients are being treated. So at the point that people were having largely palliative treatment, high sensitivity assays were not really required. But now we get to the stage where the majority of patients are achieving CR. You start to need higher sensitivity MRD assessments. And at this stage where we're at now, at the end of the chemotherapy area, where the majority of patients, or a higher proportion of patients, are achieving less than 1 in 10 to the 4 neoplastic cells at the end of treatment, you're starting to see the introduction of 1 in a million type assays to get a proper assessment. For CLL, this was the key trial that showed people that MRD was worth looking at. It was the German CLL study group trial looking at chemo versus chemoimmunotherapy, so FC versus FCR. And the patients who achieved less than 0.01% disease with FCR or FC had a very similar outcome. And equally, those patients who had greater than 1% disease with either treatment had a very similar outcome. But about 2/3 of patients receiving FCR got into this good risk group, whereas 2/3 of patients with FC were in the poor risk group. And so at that stage, it was considered that the sort of MRD assessment, although not quite ready for clinical practice, should be used in all the clinical trials. And maybe then 5 to 10 years ago, it all changed with the understanding, the development of treatments to target the B-cell receptor signaling. So we talked earlier about patients with poor outcome having these unmutated immunoglobulin genes with strong signaling through the B-cell receptor pathway, and targeting that with BTK inhibitor such as ibrutinib turned out to be clinically extremely effective, but also biologically interesting. So this is looking at the fold change in CLL count relative to baseline. And what you see when you use one of these inhibitors is that the cells actually cell numbers start to rise from 4 hours to 24 hours after first dose, stabilize over the first couple of weeks, and then gradually decline month 1, month 2 to month 6. So by month 6, you're starting to see a decrease in the cell count, and this continues to go down and then maybe plateau after 1 or 2 years of treatment. And what's happening is it's stopping the cells proliferating, but it's not killing them. So you see basically it takes a long time for all the CLL cells to die off. When we monitor the disease more closely in these patients, you're seeing a very smooth decline, and this is over 1,500 days, so several years of follow-up. Generally a very smooth decline in the number of abnormal cells, but plateauing in some patients. So for example, here's a plateau, and here's a plateau over time, whereas other patients may actually achieve very, very low levels of disease with continued treatment. Occasionally, patients don't respond to this sort of continuous therapy, and you can see that very clearly in the peripheral blood. So there's a progression. So there's been some capacity for monitoring in patients on on these BTK inhibitors, on B-cell receptor pathway inhibitors. But broadly speaking, it doesn't really matter too much whether the level of disease is 0.1%, 1%, or 10%. All of the patients, if they're on a BTK inhibitor and are still responding to it, have a good progression-free survival. So this is looking at chemo plus ibrutinib versus chemo only, and there you can see the stepwise improvement in progression-free survival per level of disease. So it seemed like minimal residual disease monitoring wasn't necessarily required if you have ibrutinib in the mix. Ibrutinib is one of the components of treatment. However, keeping patients on a treatment forever, so continuous treatment, has a number of disadvantages. It's obviously, there are no treatments that have no side effects. So if you've got an effective treatment, there are going to be some side effects, and this is problematic for patients to be on a treatment forever. It's also very costly, either to the individual or to the healthcare providers, depending on how your healthcare is provided. And of course, eventually patients start to progress, although it seems that the sort of progression through in BTK is fairly, treatment naive patients seem to be very stable for at least 5 years on the treatment. Those disadvantages of inhibiting the B-cell receptor signaling have led people to look for treatment approaches that will target the BCL2 family, and we've now, over the past few years, seen a very effective treatment, that targets BCL2, which is. And what we've seen here, rather than those very gradual, slow declines in disease numbers, you're seeing a very rapid and very deep depletion of residual disease in patients once they start venetoclax, the BCL2 inhibitor. And the kinetics of it seem to be that this is chemotherapy, so you get maybe a modest response to bendamustine rituximab in this relapsed refractory group, that then gradually declines as they come off the disease. So the majority of patients, 18 months plus, have got detectable disease or disease progression. Whereas if you stay on venetoclax, it seems the sort of peak disease clearance is about a year. Very deep depletion that can be sustained if the patient stays on venetoclax, but there is a potential to stop if you've completely depleted disease. You start to see the introduction of fixed duration chemo-free treatments. And that's where we are now at the minute. So venetoclax-based treatments resulting in patients with very low levels of disease in relapsed refractory settings, or in elderly patients with comorbidities, which is the majority of CLL patients, having very good outcomes. The vast majority of these elderly patients are actually achieving undetectable residual disease with a chemo-free combination. And they're able to stop treatment after 1 or 2 years, depending on your schema. So the MRD is kind of back in the picture. People are using it to identify the patients who have had a good response. I'll just flip back to this slide and show you this type of pattern, where if you've got less than 0.01% disease versus greater than 1% disease, if you're looking to determine whether a patient's had either needs to stay on treatment for a longer period of time or whether they can come off, you're not seeing the clinical response. Actually, you need these types of MRD assays to find out what the best situation is for the patient. And so I guess over the next few slides, we're going to talk about what the optimal approach in terms of technology is, depending on what you want to achieve, whether you want to achieve high sensitivity or whether you want to have something that works reasonably easily in the hematology clinic. I think a general situation for all MRD approaches is that the lower the level of disease, the longer the progression-free survival is going to be. We've seen this many times. We've seen it in myeloma. So your patients who have less than 1 in 10 to the 4 will do much better than patients who have morphologically detectable disease or disease at the 1% level. And that'll often be in a stepwise fashion. And we know that that if we look at 1 in a million, the patients who have undetectable disease at 1 in a million will do very well, but those who have detectable disease above that level will also do quite well, but not as well. I think the point here is, if you want to get the most information, if you want to, say, develop a curative treatment, maybe you need to look at 1 in a million, and then you'll be able to capture all of the information at the higher levels and predict what's going to happen to patients. But if you're looking at determining which treatments are best by comparing MRD responses, it doesn't necessarily matter which threshold you look at. So this is multiple myeloma over nearly 2 decades worth of studies with a variety of technologies, some very sensitive, some back in the dim and distant past, using 3-color flow cytometry, maybe less sensitive, but still the hazard ratio, the benefit for being MRD negative versus MRD positive is, broadly speaking, the same across those. That's because if you look at a very sensitive threshold, the patients who are MRD negative or below that threshold do extremely well, but the patients who are positive also do pretty well. Whereas if you look at a higher threshold, like 1 in 10 to the 4 or 1% even, the patients who are positive do very, very badly, but the patients who are under that threshold do better, but still do quite badly. So your relative benefit is fairly similar across the different thresholds. And this study from Brentwood looking in ALL suggests that at an early time point, at least, the best hazard ratio for PFS was 10 to the 4, and it was slightly worse at 1 in a million. So I think what I'm saying is there's a 1 in a million is really your target for MRD technologies. It'll capture all the information above that, but sometimes it's not what you need to get to the correct answer. Situation that you may be able to look in the peripheral blood and not just the bone marrow. So the peripheral blood is highly predictive of outcome for MRD assessment. But if you really want to capture the true extensive residual disease, then you probably have to look in the bone marrow as well. So this is patients who are positive in peripheral blood and bone marrow, and versus patients who are negative in the peripheral blood but positive in the bone marrow, versus patients who are negative at the 1 in 10 to the 4 threshold in both. And you can see that with peripheral blood, detectable versus undetectable, you get a pretty good separation in progression-free survival. But if you're looking for durable remission, it's only those patients who've cleared the bone marrow where you're seeing that sustained over a number of years. And those discrepancies between peripheral blood and bone marrow is largely down to the choice of antibody therapy that's added in. So if you have rituximab, that will probably add about a log discrepancy, about 0.9 log discrepancy between the peripheral blood and bone marrow. And you'll see a small proportion of patients who have more than 2 log differences between peripheral blood and bone marrow. If there's ibrutinib in the picture, this tends to bring the cells out from the bone marrow nodes into the peripheral blood, so there's often less discrepancy. If there's no chemo, no antibody therapy, maybe you'll see about a half a log difference between peripheral blood and bone marrow. And so in those situations with no antibody, the peripheral blood is actually very informative. If you are using therapeutic antibody, it will take a while to clear. So this is with looking at some of the latest data, peripheral blood versus bone marrow. You're still seeing about 20% uptick in the proportion of patients who are negative in the peripheral blood versus the bone marrow with obinutuzumab. It typically takes about 6 months on average and up to 12 months to clear an antibody before you start to see representative levels in the peripheral blood and bone marrow. This is the kinetics that we see from ibrutinib plus obinutuzumab. The obinutuzumab stops here, but the peak peripheral blood response is then 6 to 12 months later. And thereafter you start to see representative results in peripheral blood and bone marrow. So here's a patient who starts with obinutuzumab and ibrutinib. The anti-CD20 antibody is given till here. You see continuing depletion for the next 6 months or so. Then the cells come back out, and then you're starting to see a subsequent response to the ibrutinib only. So if you're monitoring for CLL, if there's more than 1% disease in the peripheral blood, there's not really much information to be gained from looking in the bone marrow. They're almost certainly going to have greater than 1% disease, probably a partial response morphologically. Progression-free survival in those patients is typically, median survival is 1 year or maybe even worse. On the other hand, if you have less than 0.001% disease in the peripheral blood, which we can fairly easily monitor with flow cytometry, then you've probably got less than 0.01%. There's a high probability that it's less than 0.01% disease in the bone marrow, particularly if they're more than 12 months off antibody or haven't had an antibody therapy. And there the expected progression-free survival is in the order of 5 years. So there's a lot of information that we can take from monitoring in the peripheral blood as to what the outcome is going to be. In terms of the choice of technology, we've seen molecular approaches over the years. I came into the picture around and about here, where we were moving from gels and water baths through to fluorescence IgH PCR. There's a sort of polyclonal pattern that you'll see where if you amplify all of the immunoglobulin genes and run those products out on a gel, you'll see this sort of normal distribution separated at 3 base pairs. So it looks like a bit like a hedgehog versus a monoclonal pattern where you only have no normal B cells, and then a classic pattern of monoclonal B cells on a polyclonal background. And this type of pattern was really put into the history bins by looking at quantitative PCR approaches, where you use a patient-specific assay where the amount of fluorescence released is directly related to the number of copies of the neoplastic immunoglobulin gene. But the reason I mention this sort of polyclonal versus monoclonal on the polyclonal background is that we're seeing some of those situations come through with the high throughput sequencing, where you amplify all of the immunoglobulin genes and sequence all of them, and then count the number of copies, that have the same sequence as your pre-treatment disease. And we'll talk about that a little bit later, but it's not, high throughput sequencing isn't an inherently quantitative technique, so you have to do a lot of work to make it quantitative. The two main issues about high throughput sequencing are that's kind of the fact that you're only counting rearranged immunoglobulin genes. So if you have 1%, 0.01%, or 0.0001% disease, but no normal B cells, then you're going to get the same sort of result. All of the sequences are neoplastic. You only start to get a kind of understanding of how much disease there is if you either know exactly how many total B cells there are, or you spike in some sort of reference template that tells you the number of gives you a number of kind of normal sequences as a reference. And then the second issue is that sequence amplification is not all sequences amplify the same. So this is Adaptive, who are a company in the US who provide quantitative MRD through high throughput sequencing, and they spent an awful lot of time and money controlling for bias in the way that the different immunoglobulin genes amplify. So if you have a normal B cell population and just run through with consensus primers and amplify up all the immunoglobulin genes and count them, you'll see certain immunoglobulin genes are very highly amplified. They've controlled the assay to try and get a more normal distribution here, but actually that's quite difficult to reproduce in the individual laboratory. For flow cytometry or for cellular assays, we've got a similar evolution over time, from basic morphology, clonality assessment through to disease-specific assays, which we spent some time developing at the start of the millennium, and things are moving on now through to much more higher parameters and more automated analysis. For the CLL panel, there was actually quite a lot of markers tested early on to try and identify the best way to separate CLL cells from normal B cells, and it came down to a small panel of somewhere between 8 and 10 markers that you might want to use to capture all of the neoplastic phenotypes that we see in CLL. When we were looking early on with a kind of consensus panel, regulators were also saying this is what we want for an MRD assay, and they were saying at the point at which you've developed and standardized it so that everybody's using the same assay, you're still looking at another 5 to 10 years before you can use that to approve a drug. So we realized at that point that we really want to fix this in place as much as possible to make it backwards compatible. So the development that happened over the next few years was improve the detection limit if possible, reduce the number of cells needed, but essentially make sure that we were getting a result that was consistent with the types of data that we'd had in the past. However, it's important to note that the general flow cytometry community is never happy with something static. So if you ask them, do we need to change anything? They'll always say yes. And if you ask them, what do you want to change to? Then you get a whole spectrum of different answers about what needs to be added and what needs to be taken away. So it's quite difficult, it's quite challenging to make an assay that everybody will be happy with. But I would say that hopefully the ERIC panel as a core of markers is reasonably reproducible, and maybe it's sensible given that how much people want to have some sort of stability in their assays, that core is stable and you add new and interesting things on top of that core. We spent some time trying to work out how to tell whether the markers that people were using were okay or not. So we see a variety of different CD5s and CD20s, and here's an optimal situation with the T cells there, B cell, normal B cells there, CLL nicely separated from both of them. Other maybe if you had a less good reagent set, then you can still see normal T cells and normal B cells, but it gets more difficult to tell the CLL cells from background unless you have multiple other markers in. So we went through a kind of process to work out what the optimal separation would be, which gives you a range of target values that you can use to check. You don't necessarily have to use a specific set of reagents from a supplier. You can potentially mix and match in your own setting, as long as the reagents, when they're all put together, achieve at least this sort of separation of normal subsets, so that then you can be confident that you'll still be able to see CLL against a background. So we use this kind of these targets to say whether a new set of reagents or a new set of machines even is suitable. So when we were looking at changing from a Canto to a Lyric, we just checked a number of cases to see whether we were getting the same sort of the appropriate separation with our reagents on the machines. But also it can be used to test reagents and kits, more importantly, to see whether they meet the appropriate criteria, looking at the separation in terms of positive versus negative fluorescence intensities. And so with that sort of thing, you then start to see introduction of kits that meet the relevant criteria for detecting residual disease. And on the other hand, you see other people developing more extensive assays to cover a whole different set of disorders, not just CLL, by building on the panel with extra markers. And that's our current approach now, I think, where we think flow cytometry is likely to stay for the foreseeable future, but rather than developing a whole different assays for different disorders, the simplest thing is possibly to put all of the B cell disorders that we're likely to monitor into a single tube, And so we're at about 18 colours, working reasonably well on the Coulter Cytoflex at the moment, with a panel that will not just monitor CLL, but also this is a atypical CLL that looks really more like a mantle cell lymphoma versus a Waldenstrom's lymphoma, and you can see that there's obviously different markers that will separate disease from background in different settings, but you can use just one tube to fit them all. So for flow, I think for CLL, we've got a reliable backbone of markers that will separate CLL cells from normal B cells. And we've got a setup that gives you some flexibility, potential to add additional markers. It doesn't necessarily require pre-treatment material, but I think that's beneficial if you can have it. It's got the rapid turnaround that a lot of hematology clinics want. The downside is us. So the fact that you require an operator to actually analyze the things is probably the major downside for flow cytometry versus molecular techniques. Where we would suggest any changes to the ERIC panel at the moment, for the reasons that we've discussed, that we wouldn't say any changes to the core panel, but we would definitely add ROR1. The main reason is that it makes it much easier for less experienced operators to orientate. So it's quite weakly expressed, but it's the fact that it's not expressed on other normal peripheral B cell subsets means that you can kind of semi-automate your approach, or that less experienced operators can really orientate on CLL cells quite easily. So we have a template that the less experienced operators just run and don't touch. And without any kind of manipulation, that will give you the correct results in somewhere between 50 to 60% of cases without ROR1. But if we include ROR1 in the automated gating, that goes up to more like 80 to 90% of cases where we don't then need to manipulate the analysis afterwards. We would say that clinality and pre-treatment assessment is required for atypical cases in clinical trials, and that's really more because with the newer treatment approaches, we're seeing so many atypical cases coming through. Okay, so last couple of minutes, just talking about current and future applications, how we would use monitoring, particularly for chronic lymphocytic leukemia. 2 years ago, the situation was that generally the community felt that MRD wasn't quite ready for general practice, really balanced 50-50 should be restricted to clinical trials, but felt that in the future, if FCR, if chemoimmunotherapy was replaced by targeted immunotherapy, which in the UK it nearly has been, we've now got, we've got a fairly restrictive or fairly cautious regulatory agency for treatments. They won't pay for anything that doesn't that costs too much, and they've now approved venetoclax for frontline patients in certain settings. We're seeing generally people thinking that actually treatment will be guided by minimal residual disease assessments. And when we had the ERIC workshop in 2020, a couple of weeks ago, really most people who participated were interested in assessing response, extending duration, and monitoring patients in remission after treatment. So we're seeing a real change in how people want to look at disease monitoring. In our laboratory routinely, we've actually had a fairly busy, fairly similar number of samples over the years, about 100 to 150 bone marrows, where people are sort of asking about residual disease and sort of asking about, why is there a cytopenia? Can we stop treatment? Is things changing? A reasonable number of people looking after allogeneic transplant to check whether patients are still in remission at an MRD level. And the approach to doing that has really been to say, let's have the same assay at diagnosis and follow-up, but adjust the number of events that we acquire according to the situation. So for diagnosis, we'll have a CLL tube where we're looking at 200,000 events. But if somebody's post-treatment, we'll go for a minimum of 500,000 events. And if it's a clinical trial question, Or if somebody's really looking for a sensitive response assessment, then it's 2.5 million events, but broadly speaking, the same assays, the same antibodies. And the key question, I think, for the current and future is not the 1 in a million type thing. It's really, does the person have more than 1% disease at a particular time point versus less than 0.01% or somewhere in between? And the implications for patients after a fixed duration treatment are that more than 1% disease, you've got a 50% probability of progressing within a year. If you're less than that, then over the first year, you really don't generally see any difference. So 1 year progression-free survival for less than 1% is pretty much the same, independent of how low it is. But when you start to look at the long-term picture for an individual, if they're less than 1% but more than 0.01%, 5-year progression-free survival is very low. And to actually achieve 5-year progression-free survival, you really want to be definitely less than 0.01%. And this sort of level is reasonably, it's a 500,000 event file acquisition. It's fairly simple, fairly cheap to do for patients on a rolling basis. And it doesn't seem to matter which time point you look at, 6 months, 12 months, 18 months after treatment, the profiles are very much the same. And so that's been moved in our institution through to providing an alternative for monitoring. Rather than patients coming into the clinic and having a physical assessment, we can send a pack out to them and they have the assessment done locally in their primary care facility, posted back to us, and we do an MRD assessment, a moderate sensitivity MRD assessment. It's a similar approach that we use for our chronic myeloid leukemia patients as well. And there you can see some different patterns. Somebody who's had FC a long time ago and has no detectable disease at all. Other patients who've had maybe less intensive, here, patient who's had rituximab only with a gradually increasing level over time. Here's an elderly patient who's got quite a lot of disease. Normally we'd bring them back to the clinic to get above 1 times 10 to the liter, but he's elderly, he's got comorbidities, and so it's therefore reasonable for him to stay. He's being fairly often checked up in the community, and we can see what's happening with his CLL. Here's another patient who, very young, had an FCR, which not at our centre, probably wouldn't have had FCR if he was at our centre, but was MRD positive, but very low levels for a couple of years. This is the actual picture that we were checking in the lab, and we could see a little spike around here, not sure what's going on, but then it came back again and then started to rise up here towards the end of 2019, at which point he was clearly progressing then. But actually then we knew that long before, about a year before, the levels were starting to show as a lymphocytosis. So that's how we're using it in the clinic. We obviously have also using extensively in clinical trials, trying to work out the best time points to assess and to not just measure response, but find out the best combination of different treatments and the time to use them for. I mentioned at the start that venetoclax really stops after a year, peaks after a year rather, of exposure, whereas ibrutinib, you get continued improvement in response over the years. And it's looking like from longer term studies that really 2 years of combination gives you the peak to both. And then you start to see some patients progressing and other patients continuing to respond, but really sort of plateauing out after 2 years of combined exposure in the peripheral blood and bone marrow. And an understanding that the rapidity of response has a play into that, how well people are going to do. So if you have 2 logs depletion over the first 6 months, there's something like a 75% plus chance of having MRD undetectable after 2 years of combined treatment. So the sorts of measurements that you might be asked to do is, what's the log depletion after 6 months with these new treatments? How well are they doing at 1 year or 2 years? If it's more than 1% after 1 year, then we've got a choice of either changing treatment or continuing, keeping on with a continuous treatment. Whereas if it's less than 0.0, if they've had a rapid depletion at 6 months and there's no detectable disease at 12 months, you can then start to say those patients can have a treatment holiday and come off treatment for some time, and they're likely to have prolonged progression-free survival. possibly for the future, for out of interest, I think the things that we are adding onto our core panel is not so much you can add on to maybe include different disorders, but you can also add on to look at the underlying. So if you have inhibitor treatments where you're looking at specific pathways that are affected, sometimes you know, molecular approaches give you an indication of resistance mutations that are developing. It seems to be an odd picture in chronic lymphocytic leukemia, at least. So if you've got a BTK inhibitor, you do see BTK mutations leading to drug resistance, but it's not all the patients. It's maybe only half of the patients, and within those patients, it's maybe only 10–20% of the neoplastic cells have a resistance mutation. The rest of the cells are progressing, but without a resistance mutation. This is somebody on venetoclax who's developed resistance to venetoclax, and so it's an individual patient. Half of their cells have a mutation that confers resistance to venetoclax. So it's a BCL2 mutation. The other half of the cells have kind of evolved to become resistant biologically without a mutation. So they've upregulated BCL-XL. So I think what's kind of interesting for the future is to take MRD, but also add in the biology of the disease. So we're looking at BCL2 BAX expression in the resistant cells in flow cytometry, and then in the molecular labs looking at the kind of epigenetic factors that lead to cells adapting to chemo. Okay, so that's an overview of today's topics. I'm going to stop there, and if there are any questions, I'll be very happy to take them now. Thank you very much.
Do you have some experience with CD200 positive mantle cell lymphoma?
Yeah, so it's about 10% of cases with an 1114 have some CD200 expression. Those cases would almost always be CD23 negative. So we tend to look at 223 together, and if both of those are negative in a CD5 positive B cell disorder, then you're almost you've got a very strong probability that it's mantle cell lymphoma. We have had 1 or 2 cases that are 200 positive, 23 positive, and have an 1114 translocation. So it does happen. We always check for an 1114 if there's any abnormality, sort of any abnormal phenotype, so not abnormal, atypical phenotype. And we also check CD200 negative B cell disorders if they're not obviously germinal center B cell disorders. But if it's a fully typical CLL phenotype, there's 223, 43, Raw1, and then weak 8179B. We don't look for an 1114 translocation routinely.
Okay, thank you. Next question is related to kappa lambda. Which kind do you prefer, monoclonal or polyclonal, and why?
So we prefer monoclonal. I think the polyclonal approach really was very useful in the days when you were looking in single color and trying to judge whether a profile was, if you're looking at a kind of histogram where there's going to be positives and negatives in a normal situation, and it's difficult to tell whether the negatives are genuinely immunoglobulin negative or whether it's lack of binding from the polyclonal reagent, from the monoclonal reagent. Whereas nowadays we're looking at kappa versus lambda all the time, and so if anything's double negative, you're suspicious, and it just means that with the monoclonal that we've got more kind of reproducibility. We know batch to batch that everything's going to be the same. So yeah, ever since the multicolor days for the last 10–15 years, we've used monoclonal anti-immunoglobulin reagents.
Okay, next question. Do you have some experience with CD180?
So not some. One of the disadvantages of having so many samples is that to change things it takes a lot of work. So we have to kind of make a decision to test things in detail and then do it. So the plan is for all of the potentially useful markers, such as CD180, the CD160. There's a variety of things. We're going to do that on the Cytoflex. So the days to develop the Euroflow panel, we spent about a year or so looking at starting with 100 markers and worked our way down for things that would be useful. This time we're going slightly the other way, that anything that's potentially useful, we'll look at those all together on a range of cases for a period of time. So I don't have the answer on that at the minute. Next year, maybe.
Okay. And next question about, is it possible to differentiate by immunophenotyping marginal lymphoma from variant hairy cell leukemia? If patient is in sample, we have no CD103 and we have no BRF mutation.
So without if there's no CD103, I think that's quite challenging. I'd say you'd need CD103 in a diagnostic panel for hairy cell.
We have no expression. Sorry, Andy. We have no expression.
Okay, yeah. Okay, I was going to say. So for those cases, well, so if there's no CD103, then I'd say it's not hairy cell leukemia. Typically, the difference in treatment is for hairy cell versus variants and other similar disorders. So the hairy cells will respond pretty well to basic chemotherapy, whereas the others less so, and you might need to look at different sort of treatment options. So I think if it's anything outside of typical hairy cell leukemia, then really the treatment options change. Does that kind of answer the question? I don't necessarily, the actual fine diagnosis of it would depend on histological and clinical features, and it's not necessarily something that you would try to do with flow cytometry. There's probably more variability between those associated but not hairy cell leukemia disorders than there. The variability is more in the treatment options would be less varied than the phenotypic patterns that you could see. Sorry if that does that make sense?
Thank you. Next questions again about mantle lymphoma. Do you have some experience with CD305 expression?
So LAIR1 expression in mantle cell lymphoma. So yes, so we use CD305 as our in our screening, but I think it's not necessarily so useful for mantle cell lymphoma. It's not one of the markers that you need for MRD monitoring. It doesn't necessarily separate you from other B cell disorders in that sense. I mean, it's usually slightly different it's different to normal B cells, so it still helps in picking out the populations for clonality, but it's not as sensitive as other markers for separating mantle cells from normal B cells.
Okay, I think it was something on slide, but in conclusion, what you can recommend for MRD study? Peripheral blood or bone marrow?
For CLL, then I think it depends on the situation. For a clinical trial, you have to make assessments in peripheral blood and bone marrow to really capture the full extent of the response. But for monitoring in the hematology clinic, if you've got patients who are off treatment or patients where you're looking for a response, the peripheral blood is really going to tell you all that you need to know for the next year and maybe the next few years. So I would say it depends on the situation. Trial, you need a bone marrow. Off trial, probably most of the time you can get the answer that you need from the peripheral blood, and all of the information that you need potentially if they're more than a year off antibody therapy.
Another question, can you shortly describe sample preparation for MRD study? For CLL MRD study?
I think for all of the disorders, and I guess most, if you really want to get a decent level of, decent limit of detection, you're probably going to have to pre-lyse the cells with some sort of a bulk lysis approach. We've used ammonium chloride anyway for the last few decades, so that we can start with a population of leukocytes of fixed concentration. I think that just makes it easier. You know how many cells you're going to put in. But then there are other advantages to doing it in a different way. If you just want to have a 0.01% MRD assessment, then using, let's say, like the Duraclone tube, so that kind of approach, where you add a certain volume of blood and lyse it, that can be quite, that you can certainly get decent results with that approach. I think if you do want to get high sensitivity, then you probably need to pre-lyse. And that's what we would usually do.
Thank you. And last two questions, again about mantle lymphoma. Is it necessary to confirm classical mantle lymphoma by molecular biology?
Yeah, I mean, I don't think you can make a diagnosis of mantle cell lymphoma by flow cytometry. There's plenty of cases where you would see a mantle cell phenotype and you can't find a cyclin D1 or D2 abnormality. So you maybe be able to do it with SOX11 expression. I'm not sure how well that people are finding that works by flow cytometry. I think in the UK mostly, unless there's an 11-14 translocation, then we don't call it mantle cell lymphoma usually. And so the actual diagnosis is basically it's a molecular one, but we can streamline the amount of testing that gets done by doing good flow cytometry up front. Okay.
Do you wash sample for monoclonal assessment?
Yeah, so that's one of the advantages of having a pre-lysis approach, is that you can also wash off the cytophilic immunoglobulin. So we do about 5 to 10 minutes in the warm. So with the ammonium chloride goes on into a 37-degree incubator, and that tends to nicely get rid of any cytophilic immunoglobulin, as well as allowing you to lyse the cells before you stain them. But yes, you definitely you have to wash for clonality assessment, at least two washes, whether you do it in the warm or the cold. We do that as part of the lysing process.
Final question: do you use cytochemistry test for differential diagnosis of lymphoma?
No, I'm not sure what. So, do you mean immunohistochemistry for?
Yes.
Yeah. So our laboratory is we've got benches, molecular flow cytometry and immunohistochemistry. We're all in the same laboratory together. So the flow benches are next to the immunohistochemistry bench, and the molecular labs are in sort of clean rooms around the side, and we choose the best test for whatever situation. So for MRD, minimal residual, measurable residual disease, sometimes it'll be a molecular assay, sometimes it'll be a flow assay, depending on what's most cost effective, and wherever there's the lymphoma diagnosis are probably largely driven by the immunohistochemistry, but we'll have flow in most of those cases. That means they can cut down the panels. So when we do the flow cytometry, we're largely saying, is it CLL? You can stop. You don't need to do any markers on the immunohistochemistry. Is it myeloma? Yeah, you can stop. You don't need to do any markers by immunohistochemistry. Is it a CD5 negative B lymphoproliferative disorder? We can say we think it's probably, there's plasmacytic differentiation. You might want to look out for Waldenström's and so forth, but the final diagnosis will rest on the immunohistochemistry.
Okay, thank you very much, Andy, for your extremely interesting presentation and your answers. We'll see you on close the session.
Okay, thank you very much. See you soon. So we're going to go through some cases to show you how we do the CLL post-treatment analysis for this, and we will be using the duraclone tubes. So this isn't the usual way that we do the analysis in Leeds. It's the way that we do the analysis, but it's not the usual way, not the usual antibodies that we use. We're running the duraclone tubes in a project with the European Research Initiative in CLL. Firstly, to really just assess the quality of the duraclone tubes to see whether it be applicable for a wider project. So as a result of that, some of the samples are not the greatest quality because we had to use material that we'd already analysed and finished with, and then we could use them for the duraclone tubes. But even so, even with the fact that the samples that we're using were not of the highest quality, it's clear to see that the reagents within the duraclone tube for CLL MRD analysis met the required signal to noise ratios that we would want, and we were getting good quality staining. So you'll see examples of post-treatment CLL cases stained with the duraclone, stained using the duraclone tube, but acquired on a BD machine. So there's also some oddities as a result of that acquisition. So over the years, what we have tried to do is set up an automatic template, or a template that will give us a result requiring as little manipulation as possible. The reasons for that is that some of the files are 2 million event files, and it's very slow to adjust, as you will no doubt be well aware. To adjust any gates on a 2 million event file is very slow and time consuming. And so if you can run the samples through a batch analysis and get a result without having to adjust the gates afterwards, this saves a lot of time. And the second reason is that a lot of the people in our laboratory who acquire the samples are fairly inexperienced. So some of them work part of the time in histology or molecular, and they only rotate through occasional days per week. So they're mainly focused on acquiring the data rather than having a lot of time to analyze things, samples in detail. So over the years, this is the kind of approach that seems to work best, and that includes obviously a time gate. We have a basic forward and side scatter gate just to really exclude granulocytes and debris, but again that's set very wide, and we would include doublets or larger cells in that initial analysis, because we don't want to exclude anything that might be a large cell. We have a region here to really exclude or identify the red cells using 43 versus 19. All of the normal non-B cells are 43 positive, the CLL cells will be 43 positive, 19 positive, and then normal B cells will be 43 negative, 19 positive. And then a second loose gate around all of the CD19 positive events, going a little bit lower here for the CD5 positives. And that in that way, sometimes with the newer reagents, the newer treatments, such as ibrutinib or venetoclax, you can see a slight loss in CD19 in patients as they're on treatment. So we used to use just these 3 plots here gated on B cells. So that's things, B cells would be in B, not C and D. and we were looking at 3 bivariate plots where the plots were set up so that the CLL cells would be towards the top left and normal mature B cells would be towards the bottom right. And what we normally see is some green and some red events. So the red events are things that are in all 3 CLL areas, plus some additional gates that I'll show in a second. So you'd expect CLL cells to be ROR1 positive. It's not very strong, but it's usually present, whereas all the normal B cells are ROR1 negative, normal mature B cells, and weaker 81 on the CLL cells versus the normal B cells. Obviously, the CLL cells you would expect to be CD5 positive and weak CD20. Actually, that's the less helpful gate than ROR1 and 81, because CD5 expression, it can be weak at presentation and it can be even weaker if they're on a BTK inhibitor. So we would fully expect in some cases to see CD5 being almost negative, at least on a proportion of CLL cells. It was quite a common situation. And then CD43 versus CD79B, again, a similar situation to 5 versus 20. And typically what we do is we set these regions very wide. And if you want to check whether a population that you're seeing that's colored in red here is genuinely a CLL, we're expecting, if you move in one of those regions to highlight that population better, the other plots will automatically become cleaner as well if you've got a genuine CLL population. So as you can see there, once we take out those events along the edge there, also those events along the edges here disappear. And you can do that with any of the plots in most typical CLL cases. Okay. So if we needed to clean up, we would take that sort of approach. Maybe you saw here on this radar plot a similar sort of cleanup approach. And these 2 plots that we use here are really to automate the process as much as possible. So if I go back to how it was originally, on this radar plot we have, let me just show the parameters. So going up this way, we have ROR1 and CD5, which will obviously pull CLL cells towards the top left. Going this way, we have CD19 and CD20, which will pull the normal B cells away from the CLL cells. Going this way, we have CD81, and this way we have CD43. So the progenitors have very strong 43 and 81, so they get pulled down this way. 81 is on normal B cells and very strongly on progenitors. So this sort of pulls the normal B cells away from the CLL cells. And then this region here is, I don't know if this still translate very well, but it's a fudge. It's a kind of way to get around the fact that sometimes the phenotype is atypical. And I'll show you that a little bit later, but broadly speaking, the CLL cells should be right in the middle of this area, but sometimes if you've got an atypical plot, you can capture them in here and you can see that the CLL cells that are slightly outside of the region are genuinely CLL with an atypical phenotype without having to go in and manually regate. Okay, so sorry, it's an automatic reflex to try and move regions around when they're not working as you would want them. Okay, so then we have a couple of other things to take out here. We have the total events and then the leukocytes, which is all these events in here. The limit of detection and limit of quantification we calculate automatically as 50 events divided by total leukocytes, or 20 events divided by total leukocytes for the limit of detection. And those we've shown through various studies to be reproducible thresholds. So if you have less than 20 events, different laboratories may report the result in different ways. Whereas once you have more than 20 events, most experienced operators, or all experienced operators, will detect that there's a population of suspicion, but they might get variable quantification unless there's more than 50 events as well. So then we have these total number of B cells, which are things in there and there and there. Tolerant CLL and stringent CLL. So stringent is things that are in there, there, and there. And the tolerant ones are there, and also in there. And we'll see that come into play later on. Progenitors and plasmablasts are in this region, and typically in the peripheral blood you won't see many things in that region. If you've got T cell contamination, it appears about here. If you have plasmablasts, somebody with an immune response going on, you'll see a population there. But in the bone marrow, that will be full of B progenitors, and also plasma cells will appear in there. I'm getting a very bright sunlight situation, so I might just have to adjust a blind in the setting there a second, but anyway, hopefully it'll be all right. And then polyclonal B cells, mature B cells, this number here. And then we report total B cell percentage of leukocytes, and then CLL cells as a percentage of leukocytes. And on the second sheet, we have a check on the width area analysis to check for doublets. So this looks really odd on all of the duroclone tubes that we've run, I'm afraid, because of the fact that the samples are a day old, and secondly because we weren't using the correct lysis approach. We weren't using the Coulter's recommended lysing. We were using a BD lysing agent, which didn't give us complete lysis in the setting that we were using with lots of cells. And so you saw the staining's fine, but then there will be a mix of lysed and partially lysed. So the partially lysed cells are up here. They're sort of double the size, but they're not doublets. So we see that in a lot of the plots. So hopefully you can just forgive me and ignore those for the purposes of this demonstration. And then we look at a range of other parameters just to check that the compensation is correct. And here look to see whether our signal to noise ratio is right. So this is the CD5. We're looking at CD5 on T cells versus any normal B cells. So if we've classified it as a normal B cell, we're looking at the CD5 median fluorescence intensity on there to there, and we're expecting that to be greater than 30. And as you can see here, it's a really good strong signal with low background. Looking at 200 there, and the same for CD19. We're wanting more than 10, and we've got 220. CD20 is beautiful. CD43 is beautiful. We're a little bit lower on the CD79B and CD81, but I think that's more the age of the sample. So we're getting higher background on granulocytes because the samples are a bit old. So it's not the fault of the signal. We're getting a really decent CD81 expression on normal T cells, but we've got high background because the sample is not so good. And the same for 79B. 79B, if there's anything I would be a little bit not unhappy, but maybe could do better. The CD79B is very strong, so the background CD79B is quite strong in the duroclone tube. You still get decent separation. It's still very easy to see CLL cells from normal. And when you're looking at the 43 versus 79B, in the other samples, this case has actually got a little bit higher CD79B than normal on the neoplastic cells, but usually the separation is very good here as well. Okay, so in terms of the sort of analysis we do, that result would come out as a PDF that somebody like me or one of my two colleagues who check all of the final flow, we would look at that and say, do we need to adjust it? And if we felt we need to adjust it, the sort of adjustment we would do is something like this, just to make sure we've got a really clean population, and then double check. So that's a nice singlet population on there. Scan all the QC and re-upload those. But if you have a look, what we've got is they're 0.13% of leukocytes. That change, those changes that I made, just undo them. So in that situation, they changed it from 0.16% to 0.13%. And from a clinical point of view, that is of zero significance whatsoever. So, you know, you're talking about, is it above 1% versus less than 1%? Well, it's nowhere near that threshold. Is it below 0.01% versus above 0.01%? It's nowhere near that threshold either. In fact, if we'd have just left the result as it was, it would have had the same clinical outcome. Obviously, you wouldn't want to do that if possible. So with this automate, like, you know, having a very defined template and trying to get people to move the gates as little as possible, it takes a bit of time to evolve in your own laboratory. So assuming you were using the duroclone tube, I think you could start with this sort of template, but it wouldn't be exactly ideal for your situation. How long you're incubating for, how your machine's set up, various other factors that are just unique to each individual laboratory. They make it almost, I think, difficult to have a template that will work for every single laboratory. But after a few cases, particularly if you run several normals and a few neoplastic cases through, you can start to adjust these so that it's virtually doesn't require any adjustment or minimal adjustment in your laboratory once you're going. And the main thing is, I think, with this, you can see when there's disease there. So you can see usually most of the time that when disease is present above 0.01% with ease, there's an obvious population. It's the cases where there's no disease or very low levels of disease that you might want to have a look and try and work out whether there really is genuine disease there or not. So if we move on to, so this is a typical case with no disease. And what you'll see under most circumstances, when you have, you either have disease and no B cells. This situation is actually relatively rare. Normally you have something where there's either plenty of disease and no normal B cells, so everything's up here, or you have no disease and all the B cells are normal and mature down here. And I'd say 60% of cases are in that kind of situation. You look at it, disease not there. If we look at the numbers, we've got about 10 events in the stringent, and that means that even if you acquired this again and those 10 events were genuine, if you acquired it multiple times, you still wouldn't get to a situation where they would be above 20, and the percentage is definitely well below 0.01%. So you can be quite confident looking at this without any adjustments that there is no residual disease there at the 0.01% threshold. So you could confidently report that as less than 0.01% residual disease. So then, just to get everybody used to the sort of pattern, there's a few cases where the results should hopefully be fairly straightforward. So here's another one. We've got 1 million events acquired, 800,000 of those are leukocytes. We have here 0.8% disease, 0.85%. There's virtually no reason to adjust any of the gates there. It's not going to change the result. It's clearly MRD positive. The normal B cells are also evident there. So as long as the QC is okay, we can pass that and report that as residual disease detectable 0.85%. This is, again, a standard situation. This is somebody who's on a protocol, so they've sent the peripheral blood through, even though 95% of the B cells are 95% of leukocytes in this case are CLL, and that's often the situation post-treatment. Even if the count's normal, all of the B cells are neoplastic, and you really just have a completely obvious result, which didn't probably really need an MRD assessment. So then here's another case which looking at that, I would say is probably there's no neoplastic B cells in there. So this zone is largely clear. There's a few events, when you look at them, they're all at the fringes of the normal distribution. With experience, you could probably look at that and actually report it without adjusting the gates on the SCS file, because experience tells me that when I do adjust those, because of that pattern, there's going to be nothing there. And this is one of the things that you would tweak if you were going to use this approach in your laboratory. It might be that you set as a default your 20 around there or so forth, and get something that really is more sensitive, more specific at putting the neoplastic versus normal in the right place. But here it's fairly easy to just clean that up and say, what's the cells that you're actually suspicious of? As soon as we go away from the strong 20 expressing cells, all of the other events that look like they were potentially CLL cells disappear, except for maybe a few events up here. And as soon as you hone in, as soon as you focus in on events that are more in the CLL zone than not, everything disappears. So then it's no evidence of disease. Okay, so another case. It's the fairly standard situation. Some residual disease there, maybe a few normal B cells, maybe not. It's 0.2% disease. No need to move any of the regions. Everything looks correct, and so we wouldn't adjust any gates on that. Same thing again, and this is often the way as you go through the cases. They all look fairly normal. You might have a look down here. Maybe there's some weaker CD19 on the T cells, but that's not going to. You're not missing a large percentage of the neoplastic cells. Most of the gates are actually completely fine as it came through on the automatic analysis. So what about this one? Now then, so I can't see the chat, but hopefully when you see this one after looking at all the previous ones, you would be a bit suspicious about this. Yeah, there's lots of B cells. There's some stuff that's some events that are at the edge of the normal B cells, but then there's these ones which are pulled out and separate. So you can either look in here or look in here to try and clean up. I'm going to move this way first. And hopefully things will become more CLL-like in the other regions. Wait a few minutes. Okay, there we go. So yeah, we've partially cleaned up. Moving in, we've still got some things that look more CLL than not. Let's try again here. Okay, so now you've got a population. It doesn't look like non-specific binding. It's generally within the CLL zones, and as we moved in, it's cleaned up on the other plots. So there you would go 0.037% of leukocytes have a CLL phenotype. Okay, on to the next one. So this is a similar situation. These are the ones where it's difficult, where there's lots of normal B cells and very few suspicious events. But if we take the same approach here, let's have a look at the things that have got some raw expression possibly and weak 81. And you can see there they look less like CLL cells when you zoom in on there. They've still got some CD5, but when we look at it on here, it's got that edge of non-specific binding to it. The kind of, it'll take a while to update the things. There we go. So it does appear to be somewhat discrete, but it's not fully consistent with non-specific binding. I think when we zoom in here as well, we're going to be left in a little bit of doubt. So the percentage of abnormal cells is close to the limit of quantification. The percentage is less than 0.01%. So we are going to be reasonably happy to say residual disease is below 0.01%. But the question of whether that's actually some residual disease or some non-specific binding, we can look at where they are. We can see that the side scatters, the scatter characteristics are not great. Those events are very small, but it could be just the way that the processing's been done, which, as I said, is not ideal. So that's an example of a case where we would be able to issue a definitive result at the 0.01% threshold, but would be left in some doubt as to whether there's really disease there or not. And this is one of those things where we'd want to know the history. So did they have a phenotype that was very weak RAW1, very weak 81, but strong 520 and no 43? It's highly atypical, it's unusual, it's probably not CLL. But if we knew from the previous ones that it was disease, you'd be more confident in saying there might be a low level of disease. At best, we'd say there's no detectable disease, or it's suspicious of a non-CLL type population. Okay, so this is, hopefully it's plain to see that there's something in the CLL zone, but the other cells are different in this case. So we've got some CLL cells clearly there, and this is where the plasma cells or progenitors come into the zone in a bone marrow. So you'd expect, if there were some events down here, they would be 19-pos but CD5 negative, and no CD20 whatsoever, no CD5 whatsoever, very strong 81, and bimodal on RAW1 if they're progenitors. Plasma cells would obviously be GOL1 negative. So that's the type of profile that you'd expect. The 79B is quite high on these, but you've got to remember a logarithmic scale. The normal B cells are a log higher. So although it looks like the 79B is moderate, that's the staining profile and the combination of the duraclone and the BD machine, which is a little bit higher than you'd expect. But relatively speaking, those are CD79B weak or very low. So then we get to this sort of situation. Hopefully in here, you can see that there's some CLL cells. They look reasonably convincing. And this, you've possibly got some plasmablasts. It does look like there's some normal B cells there. And the reason for showing this one is that this is the sort of right at the limit of 0.01% detection that would be required for a clinical trial. So we've set it to acquire 2 million here. We've run out of events, total events at 1.4 million. Of those, 1.2 million are leukocytes. And we're left in a situation where it's just below the MRD IWCLL threshold, but there's clearly residual disease there. If you're actually acquiring, so we usually try now under normal circumstances to acquire 2.5 million events for cases which really need a high sensitivity analysis. This will give us easily enough events to detect at the clinical threshold, the 0.01% threshold. So you would have several hundred events or 200 events, which should be very easily visible. Once you get more than 50 events, the population appearing in here is quite apparent. How you report these, it depends a little bit on what your local clinical team want. So at the moment in the UK, we have a kind of headline diagnostic comment. This is MRD negative at the IWCLL 0.0% threshold. And then within the comments, we say there is residual disease detectable below this threshold. Other ways to approach it are to use a kind of MRD summary. So MRD 4 would mean that the level of disease is below 0.01%, so less than 1 in 10 to the 4. MRD 5 would mean there's less than 0.001%, less than 1 in 10 to the 5 cells. So it doesn't meet that criteria, but it does meet the MRD 4 criteria. And then if your assay isn't able to go down to 1 in 10 to the 5, you would say that it's undetectable at the threshold. So this has got detectable disease. It would be an MRD 4. Just another way to report these. But essentially within your report, there should be an indication of the percentage, an indication of the limit of detection, limit of quantification, the total number of leukocytes looked at, so that you can have confidence when you report it as MRD less than 0.01%, that you've acquired enough events to show that. Okay, so this is I couldn't find a good example with the bone marrows of the the sample quality. Unfortunately, was very poor on this one, but it's another one where once you get in, those. It's pretty easy to see that you've got a nice clean population of CLL cells, and the numbers update around about that 0.01% threshold. So I think the bone marrow situation is particularly challenging. With a peripheral blood, if your results are not so good because of the quality of the sample, you can ask for another peripheral blood sample. And so unless it was a time point where it was impossible to repeat, we would normally ask for a repeat peripheral blood if the quality was this bad. But for a bone marrow, you usually don't have a second chance. So in this situation, the acquisition didn't go so good, which often happens because when the sample quality is not so good. But you can clearly see a population of CLL cells there. So it's certainly difficult to know what to do. You can't make a statement about every sample. Each sample has its own kind of set of conditions that may really vary as to whether you feel comfortable reporting it or not. For us in this situation, we had the analysis done the previous day on the fresh samples, so I know that result is genuine, but we also always run a clonality tube as well. And in this situation, where you have a clonality tube which shows that the CD5 positive B cells are monoclonal, you've got double confirmation with a separate assay. Okay, so when you look at this one, hopefully you'll be reasonably happy that there's no CLL there. There's some normal B cells. So at first glance, looking at these plots, there's no evidence of disease. We've acquired 1 million total events, but actually it hasn't lysed at all well. So in fact, we've only got 40,000 leukocytes. So here we could say there's no evidence of CLL, but a limit of detection is 0.05% at best. So we don't know that it's at the MRD status at the IWCLL threshold of 0.01%. We just know that there is no disease within the limits of the assay that we've done, been able to do with the sample quality. The approach that we have in Leeds is to, even if the sample quality is poor, to still attempt to still have a go at trying to get the analysis done. So here's one again. The lysis hasn't worked particularly well, but actually, the staining has worked fine, and we've got a clear population of CLL cells. So even though we only managed to acquire 170,000 leukocytes, we can still say there's 0.15% residual disease with a reasonable amount of confidence, because the staining is all good. It's just the lysing didn't work. Okay, so here's another sample. We've got 800,000 total leukocytes. There's obviously a lot of the things that are in the CLL zone are actually just the edge of the normal B cell spectrum, but there are a few events up here. So if we try and clean up, we are left with 15 events. I think even if you try and check, they're in the singlet zone, even with the limitations of the fact that we've done an unusual lysing approach. So some of the normal cells appear larger, but the results seem to look more like non-specific binding to me on that front. Again, happily, because we've acquired plenty of events, we can be very confident that there's less than 0.01% residual disease. So even if that is genuine, you're confident to say to the clinical team, the disease is definitely below 0.01%, and if it's there, it's more towards the 0.001% threshold, which means that if you were going to look in the bone marrow, there's a strong probability there'd be less than 0.01% in the bone marrow as well. Anything events that you have found, I think they probably are non-specific binding, but you would need to be acquiring maybe another 4 or 5 million events before you could make any sense out of those. But I think this is where I would favour if you have additional marker channels, and we saw this with the earlier ones. The cases that are difficult are the ones where you have a very low level of cells which have potentially a CLL phenotype, but are probably junk. And in that situation, having CD3 or having a viability marker in would be extremely helpful to get rid of those events. CD3, because if they are, sometimes you see what look like actually T cells that have managed to get a bit of CD19 attached to them that look a lot like CLL cells. They're not in the doublet zone, they're singlets. And the only way you can really tell that they're not CLL is by looking at co-expression of CD3, or actually primarily expression of CD3. So I think if you were going to, if you had, say, the Duraclone tube and you had a cytometer that would be able to manage it, running CD3 on one of your spare channels would be really helpful. We have been running on our extra channels, we have been running CD200 out of interest because the French group were running the core ERIC tube plus Roll1 plus CD200. And their view was that even though CD200 was lost with patients on ibrutinib or patients on venetoclax as well, you can see some loss of CD200. It was still sufficiently good to pull the CLL cells away from contaminating T cells that you could use CD200 expression, and that hasn't really been the case from our point of view, and it's not in the Duraclone tube. I wouldn't recommend adding that one as a backup for MRD analysis. It's obviously very good for diagnosis. Okay, so it's kind of, I can't see the chat as we're going along, so there might be questions that are appearing that I can't see. So we'll do a couple of other situations that are worth discussing, and then I'll stop and have a look primarily at the chat. So I think these last two here are the reason why we have this funny fudged region. So if you look back over the cases, most of the time the typical CLL cells are right in the middle, but every once in a while you will get an atypical case, but no normal B cells. And in that situation, we can really take all of the cells in this tolerant and stringent CLL zone. So actually we've got 1.3%, and you can see a nice population of progenitors here. Clearly within the radar plot, things look like CLL cells. There's no separate overlap. It's just that the case has quite strong 79B, quite weak 5 and weak 43, and also has quite weak CD19 as well, actually, which is something that does happen. So that's our situation there. And I've got a similar, this is another one where you can see here, very strong CD79B, very weak CD43. There's still half of the cells are in the CLL zone. We've actually got weak Roll1 as well. And I think if we do something like this. So when I move these down, you'll notice that the 20, the 79B and the 81 is still, it's about the same level or slightly less than the few normal B cells that are there. You never see CD20 on a CLL case. I don't think I've ever seen CD20 being stronger than normal B cells as you might see in, say, hairy cell leukemia or some of the marginal zone lymphomas. And equally, I've never seen the 79B being stronger than the normal B cells like you might see on some of the marginal zone lymphomas. And the same for 81. But going up to the edge, I think, is reasonable. Now, still looking at that, I think those are the normal B cells. I think all of these things in here are actually part of the CLL population. I'll give it 2 seconds just to update. Okay, so yeah, when you include all of those, it looks like the vast majority of cells there have an atypical phenotype. Very strong CD5, strong 20, weak 43, strong 79B, slightly weaker 81 with a little bit of Roll1 expression. And you know, this is again why we run the clonality assessment in all cases, because sometimes the cells aren't necessarily obviously CLL. I mean, usually if there's for most cases where there's some neoplastic cells that have been called CLL at another center, there's usually a couple of markers that are consistent with CLL. So usually some CD5 expression, often weak 20, or some Roll1 expression. So you'll almost always find some cells within the CLL zone, even if the phenotype's highly atypical. But you've just got to be cautious about how you do the gating thereafter. So I will stop at that point and see if there's any questions in the chat.
Which approach do you use or do you recommend for CD5 negative MRD CLL?
So actually, with the approach I've shown there, if it's typical apart from lack of CD5, then that's fine. You'll pick them up, and the Duraclone kit will do that as well. You have to be prepared for weak CD5 expression anyway, and I think, you know, CD5 is a good, especially for diagnosis. It's a good kind of anchor. It's a good way of orientating yourself, but it's not the most helpful marker for MRD. Lack of CD20, lack of CD79B, overexpression of 43. and underexpression of AT1 are probably stronger markers. And then with the RAW1, as I say, it's weak, but it's usually there in the vast majority of CLL cases, and it's not there on normal mature B cells. So that's how we deal with lack of CD5 expression.
Okay, thank you. Next question is, what kind of report do you prepare for clinician staff? Only numbers, or maybe some description or some conclusion about phenotype?
So we go, there's a final diagnosis in big letters that says, if the sample was sent for MRD assessment, it says MRD positive at the IWCLL threshold or MRD negative at the IWCLL 0.01% threshold. Then within the text of the report, we'll have CLL cells as a percentage of leukocytes and the absolute count if it's a peripheral blood as well. That's a dual platform count. We'll also report the percentage of B progenitors if it's a bone marrow, so that we can assess the sample quality, and we'll report the percentage of normal B cells and the absolute count of normal B cells as well, because often the question is, have they got their B cells back as well, as another part of the report. And then we will report in the text the limit of detection, the limit of quantification, and the total number of leukocytes analyzed. And then in addition, for those people who are interested, they can access the PDF plot of the analysis in the report. So we're online only, we don't do paper reports anymore. But those things are accessible within the sort of report that the clinicians can see. If they're really interested, they can see the QC export that says the CD5 signal to noise was 32, etc. But that's buried quite deep, so it's only occasional people who ever look at that sort of information.
Okay.
I think as an absolute minimum, there's a recommendation coming out that as an absolute minimum, you should state the percentage, and from a clinician point of view, the report should include at the very least the percentage of CLL cells and the limit of detection. Whereas obviously for sort of more laboratory inspectors, they want to maybe see more detail in the report than the clinicians do. Sometimes too much information can hide the actual result. I think having a nice simple report, a simple result that's easily interpretable by all the clinicians is quite helpful.
Okay, can you come back to Kaluza? And
okay,
we have a question about markers which you use to describe or to differentiate normal cells and CLL cells. As I understand, marker on top left dot plot.
So why we put things in the top left? Is the question of?
Can you share your colors of screen?
Yeah. Oh, so the markers on the radar plot.
Right or right left. Right top. Sorry.
The radar. Yeah. So. Okay. So we have CD5 and RAW1. So that will pull the CLL cells up in that direction. We have the CD79B and CD20, just hidden underneath there, but CD20 and CD79. And then we have CD81. So that's on strong on mature B cells and even stronger on progenitors. CD43, which is negative on mature B cells, but strong on progenitors and CLL cells. And so CLL and progenitors are pulled over to the left of the plot. Progenitors are pulled to the bottom. Normal B cells over here to the right. And usually, so if you have a regenerative marrow, you'll see some CD5 expression more CD5 expression than usual. So sometimes you'll see events around here, particularly just after treatment. But usually even so, typical CLL is always very well resolved, but even atypical cases are usually pulled over this way, largely because of the CD43 and the ROL1. So when we've looked at different markers, so using, say, a different CD79 or a different CD81, this orientation seems to work all the time, but the how far you pull cells in each direction varies. And so moving from one machine to another machine, we found that you have to tweak, you have to adjust hold on, sorry. You might want to adjust the length. So you might want to take that further out or further back, depending on your local settings. But you probably, that orientation seems to work. Does that make sense? So 5 and ROL1 that way, but it might be that you have to pull them further on one machine than on another machine, and CD79B and CD20 this way, but maybe you have to pull further on one machine than another machine. Does that answer the question?
Now we have another one interesting question regarding to another type of pathology, for example, for B-cell lymphoma. Do you have the same or similar approaches, standardized approaches for analysis, like for CLL?
So for mantle cell lymphoma, we would use, in addition, so for mantle cell lymphoma, CD11A, CD25 and CD200 are very helpful, in addition to 520 ROL1 and potentially 43. So mantle cell lymphomas will be 25 positive with week 22, if you can fit that in. But crucially, there'll be 11A negative or very weak, and CD200 negative or very weak. So actually, CD200 is more useful in an MRD setting for mantle cell than it is for CLL, because the normal B cells will be CD200 positive, and that doesn't help you resolve CLL from normal, but it does help you resolve mantle cell from normal. For Waldenstrom's, for marginal zone lymphoma and all the other post-germinal center disorders, CD25 positive, CD22 weak is a kind of, they're very useful. Lack of CD305 or weak CD305 is also very useful. And then CXCR5 or CCR6 and or CCR6, we've found those to be core markers for MRD assessment, but that's not well published, and they're not things that people often use routinely. So you've got to be really interested in doing that if you're going to buy in CXCR5, CCR6, I think. It's often not so much of an MRD question. I think it's a building MRD question in Waldenstrom's. And there's certainly a lot of use for looking at mantle cell lymphoma MRD, but because those diseases are not so well distributed in the peripheral blood and bone marrow, it's a bit more challenging than CLL. And then at the further end of the spectrum, follicular lymphoma and some of the diffuse large B-cell lymphomas. Well, for follicular lymphoma, you can often have very little disease in the peripheral blood and bone marrow and extensive nodal disease. Actually, we've found for most of the purposes that we get a reasonable enough answer for what the clinicians want with quite high sensitivity, just with our standard B-cell screen, which looks at CD305 and CD10, 9 and 20 with clonality. That actually suffices for the clinical question, but we don't have a deep interest in doing high sensitivity analysis, so we haven't tested follicular lymphoma. And then for diffuse B-cell lymphoma, well, it's basically whatever disease they're derived from use the same markers. So if it's a germinal center one, we haven't got so much good markers in leads, but CD10, CD305, kappa lambda, 1920 seems to work fairly well for germinal center B cell disorders. For post-germinal center B cell disorders, the same markers that we would use for Waldenstrom's and some of the DLBLs lack HLA-DR expression as well, which is very, if you know that, then that's easy to track because there's not many B cells that don't express HLA-DR. That's about.
We have some discussion about ROR1. Can you share your experience about these markers, not only for example, for MRD testing, but on primary immunophenotyping before treatment? What do you think about this marker?
And what was, sorry, not only for diagnosis, but the second part of the question was?
Do you use this marker ROR1 for MRD testing only, or for primary immunophenotyping too, before treatment?
Well, so I think it's probably now one of our main key diagnostic markers, because if the case is ROR1 negative, but has CD5 expression, then you're quite unsure of a diagnosis of CLL if there's no ROR1 expression. It's very unusual. Equally, if a case has got ROR1 expression, you might be looking for mantle cell lymphoma in the same way that you'd be suspicious about lack of CD200 on the CD5 positive case. Expression of ROR1 on anything other than B progenitors and CLL, it's almost uniquely on mantle cell lymphoma, or sometimes acute lymphoblastic leukemia, but usually that's not, it's not a difficult clinical question. If somebody's got ALL, you're not really typically looking for mature B cell markers. So we, in our kind of simple schema, if you reduce it down to the minimum number of markers, ROR1 43 positive disorders, ROR1 positive, CD43 positive is probably CLL. CD10 negative, ROR1 negative, CD3 negative is probably a post-germinal center B cell disorder. CD5 positive with variable ROR1 or 43 is probably mantle cell lymphoma. And then CD10 positive, CD305 negative is a germinal center B cell disorder. If you had to limit me to a couple of markers, those would be my ones: CD10, CD305, ROR1, CD43, and CD5.
Okay.
Does that answer the question? I'm not sure if that answered the question or not. But
thank you, and thank you very much for your presentation. For the session.
It's nice to see. It's nice to see everybody. Anyway, I hope you're all doing okay, wherever you're, whatever this current situation is in your country. I hope everybody's staying as safe as possible. Thank you very much for having me.